Hello, and welcome to part 2 of this series on imaging of the ovaries. Today we're going to talk about physiological cysts. Let's talk first about a follicular cyst. Well, what is that? We mentioned that multiple follicles develop early in the menstrual cycle, but one of these becomes what we call the dominant follicle, while the others regress, and this dominant follicle goes on to rupture and cause ovulation as the oocyte within it heads down the fallopian tube. However, if the follicle fails to ovulate, or indeed fails to regress from its cystic form, we can get what's called a follicular cyst. Now, what is the upper limit of normal in size of a follicle? Well, generally speaking, it's taken to be 3 centimeters. As we mentioned in the last talk, a follicle will be simple internally. That is, it will have a smooth border, it will have an anechoic contents, it will have acoustic enhancement behind it. We often identify these normally, and if they are 5 centimeters or less in a premenopausal patient, no follow-up is required. If they are greater than 5 centimeters, we can rescan the patient in 2 to 3 cycles and we would expect them to resolve. It's quite rare for a follicular cyst to be greater than 8 centimeters, and we would usually think that there might be an alternative cause. I should mention that follicular cysts clearly only occur in premenopausal patients, because only premenopausal patients can ovulate. The only exception is if they are retained and do not resolve at the period during menopause, and therefore they can continue after the menopause has taken place. But we shouldn't get a follicular cyst arising de novo during the menopause. So what do they look like? Well, here we can see a simple cyst in the ovary, which is slightly greater than 3 centimeters in this case, and it's anechoic. We don't have any solid elements internally, and it has a very smooth border. When we're evaluating ovarian cysts, the border of the lesion is extremely important. Malignant lesions tend to have irregular borders, whereas benign cysts and simple cysts tend to have very smooth borders. Follicular cysts and follicles can grow very rapidly. Here's a patient who is being staged for lymphoma. She had an initial CT scan when she came in, demonstrating a small cyst here, or small follicle should I say, which I think was about 16-17 millimeters, I'm not quite sure. 6 days later the patient had a PET scan for full staging of the lymphoma, and it demonstrated a marked increase in size of the follicle into what we would assume to be a follicular cyst. Because the patient is going to have treatment and because the size change has been so rapid, we're not really very concerned about it. And the patient did have a post-treatment PET scan after their lymphoma when it had completely regressed. I'm just going to show you what the PET-only appearance looked like. Here we can see that follicular cyst, just a little bit of peripheral activity and central photopenia, very much in contrast to the appearance we had with the corpus luteum. So that's what we would expect for a benign follicular cyst. Now you can have some apparent complex elements, so this is reverberation artifact or perhaps a tiny bit of debris within the cyst. Here we have perhaps a daughter cyst or a little loculation. This is quite unusual, and we wish to perform a rescan perhaps in this patient, but you can see some occasional septations or this kind of appearance in follicular cysts. Everything else looks okay. It's otherwise simple. There is a very smooth border present and no solid elements identifiable. And this did regress down nicely. I don't even know if the patient was rescanned 2 cycles later, and this may be a follicle from a new follicle rather than the same one. So let's talk now about corpus luteum and hemorrhagic cysts. Well, a corpus luteum may fail to regress, as it normally does, into a corpora albicans, as we discussed in the last talk. Or alternatively, hemorrhage can occur into a follicle. These can result in corpus luteum cysts and hemorrhagic cysts. They may enlarge and show an irregular appearance internally, but the fundamental characteristics will be similar to those of a corpus luteum. I should also emphasize that a corpus luteum cyst may continue to produce progesterone. This can result in dysfunctional uterine bleeding because the lining of the uterus will be maintained longer than expected and then may be abruptly shed, resulting in abnormal bleeding. The patient may then be brought to the hospital or may be given an appointment to attend for an ultrasound examination for abnormal bleeding, and a hemorrhagic cyst may be discovered, and we have to make sure that we don't attribute that to a cancer and we correctly identify it as a hemorrhagic cyst. Hemorrhagic cysts should, like follicular cysts, resolve over 2 to 3 cycles. Just going to refresh you with the corpus luteum here to let you know the classic appearances. A round cystic structure with strong peripheral enhancement, and there can be internal contents, which can be very complex. If you look at this patient, a very thick wall, probably more like the corpus luteum I showed you in the last talk, very irregular internal contents, and an intermittent peripheral area of enhancement. It looks quite different to this one here, but you can see that fundamentally they have the same basic building blocks. Let's have a look at another one. Here's a more cystic hemorrhagic, here's a more cyst-containing hemorrhagic cyst with relatively little solid elements internally. The solid elements don't have enhancement. There's strong peripheral enhancement, which is not unusual. Another example, peripheral enhancement, and you can have a multicystic appearance. This loculated appearance is quite common in hemorrhagic cysts. Again, as I was emphasizing earlier, very important to look at the border. You can see a nice smooth border to this cyst all the way around. These are the classic appearances of a hemorrhagic cyst. How big was this one? 43 millimeters. One thing I'd like to emphasize about this cyst, which is very useful if you can find it, you can see this perfectly straight border in the clot here. It would be very unusual for a cancer to have this appearance. And sometimes you can see that the clot, which is what makes up the internal contents of the cyst, has become retracted or pulled back from the edges and has a concave internal appearance. So you might get a piece of clot looking like this, with a concave internal appearance, whereas malignant tumours tend to be pushing out all the time, pushing out in the middle and pushing out on the margin, like this. And because this is less than 5 centimeters, we're able to just ignore it and it will resolve spontaneously. Just like a follicular cyst, if we identify a hemorrhagic cyst which is 5 centimeters or less, we can consider that to be physiological and no further imaging is required. If it's greater than 5 centimeters, we should obtain a rescan within 2 to 3 cycles. Here's a patient who is being followed up for colorectal cancer. This is a large fibroid in the uterus. They were shown to have a cyst in the right ovary, which is 5 centimeters. And perhaps you can see there's a very small area of complexity here, just some sort of faint wisp of enhancement, possibly, but it's difficult to say. So an ultrasound was requested. Here we can see a well-defined cyst with a large solid portion. However, the central portion doesn't have any enhancement, and it measures 26 by 22 by 22 millimeters. Let's have a look at the report. Atypical, irregular, heterogeneous structure. I wouldn't particularly agree because I think this has a very smooth margin. The internal appearances are not concerning at all because there's no enhancement, and we can see here that concave appearance which we often see in hemorrhagic cysts. Peripheral vascularity, again, that's entirely expected from a hemorrhagic cyst. Query hemorrhagic cyst, query complex cyst. So this is a very unhelpful report. The reporter has toyed with the idea that it might be a hemorrhagic cyst and this might be clot, but then they've spoiled it really by saying it could be a complex cyst. What does that mean? This is a word we should not use in association with ovarian cysts. We should never use this word because, like a bulky hilum or bulky uterus, it's rather meaningless. And they've said this could be cancer and they've alerted it, but in reality this abnormality here is demonstrating all the findings of a resolving hemorrhagic cyst, not least because it was 5 centimeters before and now it's 2.6 centimeters, so it's clearly reducing in size and therefore it can't be tumour. That emphasizes another aspect of these scans. You've always got to look at the previous imaging to see how this may have changed over time. Here's another typical hemorrhagic cyst, a well-defined border. This is the only bit we can't see very clearly, the rest of it is very smooth. And when you see some malignant ovarian cysts later, you'll see the difference. The internal straight border here to this clot. There's some echoes within this fluid here. That's probably due to a certain amount of blood within the fluid component of the lesion, and there's a septation. Some peripheral flow as well. Here's a dense hemorrhagic cyst. This is another common appearance. Peripheral flow. This is what I like to call a rather solid hemorrhagic cyst with relatively little liquid component. It's measured at 4.9 by 4.4 by 4 centimeters. And the report says hemorrhagic cyst, suggestive of a hemorrhagic functional cyst. No rescan needed. Less than 5 centimeters, all the features of a hemorrhagic cyst, no rescan required. Excellent report by our sonographer here. So this patient, we can finish with them and there won't be any further confusion. Here's another hemorrhagic cyst. This one was identified as being greater than 5 centimeters, so straight away a follow-up will be needed. Very irregular internal appearance. It's quite complex vascular pattern. I don't know what was going on here, whether there were two hemorrhagic cysts together, but clearly a rescan is required. There is, however, a relatively smooth border. In this portion, we obviously can't evaluate the border of this part here on this particular image, but we followed the patient up and it returned to normal. So it was just a hemorrhagic cyst. Just to summarize about a hemorrhagic cyst, well-defined border, that's a very important feature to look for. The clot may have retracted edges. The internal contents may have retracted edges, which will identify it as a clot. That's never 100%, but it is a useful finding to look for. Of course, there'll be absent colour flow within the clot. A clot won't be vascularized, whereas a tumour will. Internal contents showing colour flow, genuine colour flow, is due to a tumour of some type. But strong peripheral flow is entirely expected. One thing I didn't mention is when you perform an ultrasound, when you are performing ultrasound examination on hemorrhagic cysts, by moving the probe in your hand backwards and forwards, you can move the ovarian cyst slightly. You can push it away rapidly from your probe, and you can sometimes see the clot moving independently of the cyst wall, which can occur in a clot which is loosely attached. This won't occur in a tumour. Of course, you would tell the patient before you do that so they understand what's going on. And as I mentioned, they will resolve over 2 to 3 cycles. Quickly, just to finish, the MRI appearances of hemorrhagic cysts. This is a T1 weighted fat suppressed image and high signal, which is probably due to methemoglobin, which causes high signal on T1 weighted images. This is the classic appearance of a hemorrhagic cyst. On T2, it's low signal due to dephasing of the proton spins by hemosiderin degradation products. You may also see a fluid level. And the degree of low signal on T2 can vary. These two hemorrhagic cysts here have are not very dark. That's probably due to the fact there's not much hemosiderin within the cysts. There's probably a large fluid component, whereas this hemorrhagic cyst has probably a very high concentration of hemosiderin, which is dephasing the proton spins. And it's just another appearance of a hemorrhagic cyst. So I think we'll leave it at that, and in the next talk we'll discuss malignant cystic ovarian tumours. Thank you.